Welcome back, everyone, to our next edition of the Down Syndrome Center of Western Pennsylvania podcast. I'm your host, Dr. Kishore Velody. Well, I can't believe that we are already on our 10th podcast. Thanks to you, our dedicated listeners, we've just gone over 2,000 individual downloads for these podcasts. I'm glad that you're finding these podcasts helpful, but please continue to let us know the topics that you'd like covered or any other helpful suggestions that you might have. Well, today, I'm glad to be joined by Dr. Todd Otteson, who is a pediatric ENT, or ear, nose, and throat, physician here at Children's Hospital of Pittsburgh. Dr. Otteson quickly has become one of our favorite ENT doctors here at the center. We like to call him the ENT Doctor to the Stars. But unfortunately for all of us, Dr. Otteson is going to be moving on towards a new career opportunity, but I thought I should get him on the podcast before he leaves. Well, thanks, Todd, for joining us today on this podcast. Today I'd like to get your approach to ear infections, otherwise known as acute otitis media. But before we get to the questions, could you please give our listeners an idea of your training background?
Sure. So after finishing medical school, I did 1 year of general surgery and then 4 years of otolaryngology residency or ENT residency. And that was anything from sinus surgery to ear surgery to even a little bit of facial plastic surgery, head and neck cancer, so it was everything. And then I did a 2-year fellowship here in Pittsburgh at Children's just for specialty pediatric otolaryngology. And that's the more either complicated patients or complicated cases as it relates to the ear, nose, and throat problems.
Okay, well, thank you for that background. It certainly does take several years to become a pediatric ENT specialist. Well, what do you say we just jump right into this podcast? Can you give me your simplest definition for what an ear infection is?
Sure. So an ear infection or otitis media basically is an infection of the eardrum and where there's fluid, usually pus, in the middle ear space, so behind the eardrum. And it's diagnosed really by symptoms. So taking a good history, of course, is important, but also the physical exam.
Thanks, Todd. I couldn't agree more that the history and exam findings are extremely important. An ear infection is more than just a fussy child who is tugging at their ears. Their exam really needs to show a red, bulging eardrum from all the infectious fluid behind it that prevents that eardrum from moving normally. With all that antibiotic resistance going around these days, it's more important now than ever to make sure that the diagnosis is made correctly. Well, one thing we know for sure is that ear infections seem to be more common in Down syndrome. Can you share why that might be?
I think probably there's a couple of issues. One is ear infections are more common in children who have abnormal eustachian tube function. So the eustachian tube connects the middle ear to the back of the nose. So it is an age-related thing. So the younger children don't have as good eustachian tube function. But even related to their peers, children with Down syndrome generally have worse eustachian tube function. So that's a setup for additional infections. That's the first thing. And I feel like in general that the immunity of children with Down syndrome is maybe a little bit worse perhaps than other children as well. So it's sort of two strikes. The one is the anatomy of the eustachian tube, and the other is just the natural immunity, the body's ability to fight infection. I think that a separate issue, but I think also important, is children with Down syndrome have quite narrow ear canals, especially the younger infants, obviously, because they're smaller. But that can make it more of a challenge to actually even diagnose the ear infection because, again, it was by our physical exam, and that can sometimes be difficult. So it sometimes is some wrangling in the clinic to try and clean out earwax and make sure that we get a good diagnosis and the correct diagnosis.
Well, Todd, wrangling and cleaning out earwax are not my favorite things, so I'm glad that ENT is just always a referral away. But now let's get on to the next question. Families often ask me about ear tube placement. Could you start us off with your explanation of what ear tubes are?
Sure. So the tubes themselves, sometimes they're known as ventilation tubes, which actually describes their purpose quite nicely. So basically, a tube is placed by making a small incision in the eardrum we drain any fluid that's there at that time, and then the tube goes in. So basically the tube is a grommet that just spans the eardrum. So it allows air or ventilates the middle ear space. So, and that allowing that air in makes the whole lining of the middle ear healthier. So it cuts down on the number of infections, but also the severity. That pus behind the eardrum is what causes the fever and the symptoms of the pain, all of that. So with the tube in and inability for that fluid to recollect, that's why tubes are helpful.
Okay, well, which patients should get ear tubes? Are there guidelines that you follow to make those decisions?
So the criteria to consider placing tubes are if there have been 3 or more infections in 6 months or 4 or more infections in 12 months. That's for the infections themselves. A separate reason, but equally as valid, is if we've had fluid behind the eardrum, both sides, for longer than 3 months. And I would consider both of those equally as important in children who have Down syndrome, because I would be a little more aggressive about recommending tubes in that case, because I don't want any middle ear fluid to cause any hearing concerns, because I want to make sure that there's not any strike against that child as it relates to communication and speech production and all of that. So I want ears to be a non-issue with that type of development.
Thanks, Todd. I mean, we know that hearing issues can result in speech difficulties, and we know that speech delays are more common in children with Down syndrome, even if they have normal hearing. However, something that's potentially preventable, like hearing loss, contributing to further speech delays in our kids, should really be avoided if at all possible. Can I just clarify one thing for our listeners? Are you saying that a child can have fluid behind their eardrum that's not infected, but that this can also lead to hearing difficulties?
That's exactly right. So often there can be fluid behind the eardrum, but it's not necessarily infected fluid. And that's where the physical exam is helpful. There have been studies done before to test exactly how long it takes for fluid to clear and reabsorb after an infection. I usually will tell families that about half of children will still have fluid 1 month after an ear infection. 25% will still have fluid at 2 months, and 10% will still have fluid at 3 months. And it's at that 3-month point is when we would consider placing tubes if there's still fluid there.
Okay, so let's say the decision has been made to place the ear tubes. Can you take our listeners through what to expect on the day of the procedure itself?
Sure. They usually will have the child come probably an hour and a half before the scheduled time for surgery so that they can be examined by the anesthesia team, make sure everything's good. And then once we're in the room, the anesthesia team will place a mask over the patient's nose and mouth so that they can breathe the inhaled anesthesia. And really it's just a couple or 3 breaths and they'll be off to sleep. And then once they're asleep, then we use a microscope and everything is just through the ear canal. So I just would place a small incision, both eardrums. There's a small suction so that we would suction out any fluid that's there, and then place the tubes that we said is a little bit like a grommet. Children who have Down syndrome, as we mentioned, have smaller ear canals. So placing tubes can be a bit more of a challenge. I sometimes will tell families it's a little like doing jumping jacks in a closet. So I'll usually allot a few extra minutes just because I know that it's going to be a little bit more of a challenge. And then once the tubes are in, probably, 5 minutes, and we're starting to wake up. So we head off to the recovery room. So from entering the door to the operating room to leaving the door of the operating room is anywhere from 10 to 20 minutes. And then they'll be in the recovery room probably for an hour just to make sure that they're waking up well and drinking well. And then they'll be on their way home.
And what about after they're home? What do families need to be aware of in terms of taking care of the tubes?
I usually recommend that we use some antibiotic ear drops for about a week. And mostly that's to help with any inflammation still that's in the middle ear. Even though we've drained the fluid, sometimes there can still be some infection or inflammation there. So the drops can be helpful. They also can be helpful about making sure that the tube doesn't get blocked with any of the dry drainage. It's not uncommon to have drainage for the first few days right after surgery, and it can sometimes even be bloody drainage if that's been inflamed or infected. The follow-up usually includes a visit in the ENT clinic about 1 month after surgery. We'll check the tubes, check on the tube position, and make sure everything looks open. And then, if possible, we'll get a hearing test on that day. Sometimes, if we're not so cooperative, the information is limited, but we'll take what we can get. With regard to precautions, we usually recommend that we protect the ears from having water go in. At the pre-op visit, we'll usually fit the child with earplugs that we like to have used for swimming or bathing.
Okay, so there's definitely some post-operative care that families are going to need to keep in mind. So after the tubes are in place, do they typically need to be taken out again in the operating room, or will they fall out on their own?
So the average length of time that the tubes stay in place is, there was a study done here in Pittsburgh that showed about 14 and a half months. So I'll usually tell families between a year and a half that the tubes are in place. And the vast majority of the time they'll fall out on their own. If the tubes have been in 3 years or more, that's when I would recommend going back to the operating room and removing them and patching any hole that remains. Just because beyond the 3 years, the chance of having a hole that doesn't heal is higher. Taking all that into account, though, children with Down syndrome, for whatever reason, they seem to extrude their tubes sooner than the average. And I will usually have that discussion with parents so we're on the same page. And it means I usually will check on children who have Down syndrome with their tubes more frequently. So instead of a yearly visit, I'll probably see them in 6 months, and then every 3 months instead of every 6, something like that.
That's good to know. Well, it's already time to wrap up this podcast. Todd, could you give us your top 2 reasons why you think ear tubes might be beneficial to a patient with Down syndrome who has maybe recurrent ear infections or chronic middle ear fluid?
I think the biggest one is just it cuts down on the number and the severity of the infections. That's really the primary purpose of the tubes. I think a secondary benefit I alluded to, it can help with keeping on track with speech and language development, which I think is really crucial in children with Down syndrome. So that's, I think, the 2 big issues.
All right. Hey, Todd, thanks so much for joining us here today to talk about ear infections in kids with Down syndrome.
Well, I really appreciate the opportunity to be here. It's been great.
Well, I'm really looking forward to having you back again soon to discuss more ENT-related issues in Down syndrome. Until then, to our listeners, we'll talk to you soon. Bye-bye.